Hello, my name is John Marshall. I'm from Georgetown University. I'm the Chief of Hematology Oncology there, and this is another one of my installments on the Medscape video blogs, really focusing on GI oncology and oncology in general. And I wanted to kind of take us today to a little bit different place, something that may be a common theme across all of our practices, and this is the concept of end-of-life or last-line therapy. You know, I was at a meeting recently, and there was a question that was asked of a bunch of oncologists in the room, and it was looking at really third-line choices and fourth-line choices for treatment for patients with metastatic colon cancer. And I've seen this happen a lot, and I'm always surprised about just how many physicians will, for example, give an EGFR antibody after a patient has already progressed on a different EGFR antibody, or how many folks are interested in the concept of taking drugs like mitomycin or other medicines into this refractory metastatic colon cancer patient. And I often wonder why we do that and why a patient would accept that. And I think it's really quite an interesting area of research. In fact, one of my friends up at Fox Chase, a guy named Neil Maripol, studied this specifically in a phase 1 patient population. Why would patients accept this kind of treatment? And we were talking about this at the meeting, and one of the common themes that a physician will answer here is that a patient wants this treatment, that they want the therapy. And I thought, well, would they really if they knew exactly what they'd be getting into? Toxicity with essentially no chance of benefit. And I thought, well, why would a patient go to that extreme? Why would they go to that place? And of course, we all know the answer to that. It's that a patient very much is interested in maintaining hope. This sort of any chance that they might live longer, any possibility, even the slimmest of chance that they would have some benefit from treatment. They would accept almost any toxicity for that benefit. And that maintenance of hope becomes one of those things that really ties an oncologist and their patients together. And when they talk about, or when we talk to patients about stopping treatment, they really use language that's very negative. They talk about quitting and giving up. That this is really, they've stopped fighting anymore. They've stopped living anymore. And despite our best efforts to back them off that position, I think they really dig their heels in on this and say, I want some treatment, because any other alternative is essentially rolling over and dying. Now, I'm kind of lucky in the sense that I run a phase 1 program. And so I've always kind of got a justified choice for patients. If they're well enough to have treatment, we typically will have some investigational medicine that we can offer them. And of course, we feel better about doing that because, one, we don't know what the potential benefit is. And of course, going on to a clinical trial we think is a noble cause for patients to do. So when I think about this, I think about this balance that we have between offering hope, maintaining hope, even though it might be a false hope, versus what I call having the talk, or sitting down with a patient and saying, this is really we should stop here. This is the last thing we should be doing, and we should be moving on. And then I started to extend this discussion or thought to the rest of our interactions with other medical professionals. And I think about when we have patients on the inpatient service, and we have other consultants coming in. When they come and see one of our patients, one of their immediate reflexes is, oh, this patient should be a DNR. Why are we wasting medical resources on this patient? And on the other hand, we often fight back against that opinion and say, because this patient might do better. They might benefit from treatment, and we are sort of with the patient. We're the advocate for the patient in maintaining this hope, even though it might be a false hope. So I'm not saying that there's one position that's right or wrong. I just think as we go forward in medicine, I think we have to recognize these aspects about ourselves. That frankly, it is easier to go in there and offer mitomycin to a patient with refractory colon cancer than in fact it is to sit down in the middle of the clinic and have an extensive discussion about end of life and stopping treatment. But I think sometimes we have to, in recognizing that, realize that frankly the right answer in many cases is going in there and having that difficult talk instead of maintaining therapies that really have very little chance of helping. Just food for thought early on a Tuesday morning before clinic. My name's John Marshall. Thanks for joining me.